Welcome to Dateline Health. This is Fred Lippman coming to you from Nova Southeastern University. And as I usually say, this is your show, and there's always so many questions that come to us. And as I always say to you, and you, I guess maybe you're not quite tired of hearing it, but the three most quizzed areas of us are: tell us about cancer, tell us about cardiac diseases, tell us about these new minimally invasive interventional procedures. Everybody's interested in that. So here we got two wonderful guests that are going to talk about interventional procedures, but this time it's for gastrointestinal disorders and cancers. Sitting in front of me, two doctors. One is David Forcione. That's a good, nice Italian name. And then we got Dr. Steven Steinberg. Good to see you, sir.
Pleasure.
Dr. Forcione, we'll start with you. Tell me about what's going on at the Center for Advanced Therapy in Endoscopy.
So a lot of exciting things are going on, from traditional endoscopic procedures to the latest in GI interventional endoscopy. We're able to offer the full gamut of procedures and technologies for patients with gastrointestinal malignancies, pancreatic disease, diseases of the bile duct, and really using the most up-to-date procedural technologies and equipment. We're able to do things that are traditionally done in the realm of surgery, radiology, and have largely been relegated to academic centers, but we're now able to, based on our experience and our availability of equipment, we're able to do that at Boca Raton Regional Hospital.
Well, I'm glad you gave us that preface, because I wanted to get to Dr. Steinberg second, sort of a trick I just pulled on you, because Dr. Steinberg has been at Boca Raton Regional Hospital for quite, I would say, a decade. And he's seen the transformation of really a wonderful hospital that preceded this 10 years, but now it's become really a major center for the new procedural ventures, whether it be in your area or cardiac area or neurologic areas. And like I said, the folks out here are very, very interested in minimally invasive techniques.
The Center for Advanced Therapeutic Endoscopy at Boca Regional Hospital. And I think this has evolved over the last 10 years. And it's been an effort aimed at bringing people with special skills and unique skills into the community, into our region, to help offer the kinds of therapy, the kinds of things that people used to have to travel for. And you mentioned minimally invasive endoscopy or minimally invasive surgery, and that's a really important part of the kinds of things that we do. And it's important to recognize that minimally invasive surgery is a moving target, right? It used to be that minimally invasive surgery meant that the incision that the patient got was smaller. Then it was we did it through the mouth, or we did it in a different way, each time limiting the amount of injury to normal tissue and therefore limiting the recovery time so that people would have a much better experience, less pain, less time to back to their normal activities. And so many of the things that we get to do fall into that category. So we're able to treat early cancers of the esophagus in a 20-minute endoscopic procedure rather than in a surgical procedure that removes the whole esophagus. We're able to do the same in the stomach often, the same thing in the rectum and the colon, as a way of, again, achieving the same results with a much less invasive activity for the patient. So that's probably 60% of what we do are minimally invasive versions of things that used to be more intrusive. The other part of what we do is imaging kinds of things. And that has to do a lot with patients who might be under treatment or evaluation for malignancies, where our task is to visualize things that aren't otherwise easily seen. It may be to place gold seeds in the tumor so that the radiation therapist can get a really sharp target and get a much better result, a minimally invasive result. It may be that we offer primary treatment through imaging techniques that are now available to us. So it's been really exciting to be a part of this 10-year evolution, and particularly exciting to have Dr. Forcione join us, because he brings a whole new array of tools and activities from his previous academic appointment.
That's a very good point, because I've been telling our viewers now, we're in our 18th year of doing this, and I keep on telling people how the whole healthcare team force has changed and is changing in not only Florida, South Florida, but in Florida, because of the opportunities that are available for highly trained and highly skilled individuals. I think it's a tremendous advantage to the population that use the show. I mean, nothing against all the wonderful, pioneer physicians that were here to create the corpus of, Boca Regional, the Boca Raton Regional Hospital has been there for a long time. You got to give a lot of credit to the people who put their knowledge on the line to do what they thought was the best. Now you have the privilege of having a lot of attention by a lot of benefactors, and I would say that kindly, and it gives you the opportunity to bring in people like Dr. David Forcione. Correct? Tell me, how do you feel?
I feel very fortunate to be here. I'm obviously blessed to have been part of a larger academic setting for many years, to get really solid training and experience and exposure to a lot of complex conditions. But I feel very fortunate to now be in an institution with colleagues who share the same passion and same vision for bringing the latest and greatest in medical technology and equipment to serve the patients of this region. And it's important to note that both Dr. Steinberg and I work together very closely with our colleagues in surgery, radiology, and oncology to manage these patients. This is a multidisciplinary approach, and patients are best served when we manage patients together with other experts. We don't do anything, we're not doing things in isolation. We're doing things in collaboration with other providers to provide really the best care possible.
It reminds me, and both of you can tell me if I'm correct or incorrect, but it reminds me of, if you talk about how both of you were trained in your academic residential fellowship years, you always had grand rounds. But now it's the collective knowledge and the cooperation and the collaboration of the medical team that is bringing better results and better opportunity for the people who are watching, who often fear certain styles of care, and particularly in the areas that you're involved in. Let me give you an oversimplistic thing that we get a lot of comments over the years, and everybody talks to me about, this is I'm sure one of your favorite subject areas. Everyone talks to me about, well, I really should get a colonoscopy, but the preparation is so bad, and this and that, and I feel this and that, and it's just the worst. I mean, if I could just have a colonoscopy without prepping, it'd be great, all right? It's oversimplistic comments, but that prevents the people who are watching, and I try to bring people of your knowledge and style to the show. The area that you're involved in is sometimes rejected, and oversimplistically, like I said, I used the issue of colonoscopy, but it's the same thing. I can't tell you how many times I hear from people that said, I have this ongoing regurgitation, I got this, I don't know whether I got heartburn, I got this. We know what they have to do. It's in your hands, Dr.
But I think that's really important, and it's particularly important to the group of patients who are over the age of 70, because the minimally invasive techniques that we now have make it so that we can bring that kind of healthcare that you're talking about and the kind of outcomes that you're talking about safely to that population. there was always a time, the risk of undergoing any procedure increases the older one is for a variety of reasons. And if we can make things less invasive, less intrusive, then it means that people who might otherwise be in a position to have access to a particular kind of treatment now suddenly can do that. And so, you raise the issue, for example, of regurgitation and a condition that this ultimately leads to, which is called Barrett's esophagus, right? It's the change that the esophagus undergoes when it has been exposed to acid for too long a period of time. And that's probably the most important cause of esophageal cancer in our country right now. And yet it's something that we can do surveillance on. We can look and see whether somebody has it with easy outpatient treatments. We can treat early cancers as they occur. We can keep people from getting into a position where the disease or the condition actually affects the quality of their life and the ability to do things they want to do. And I think that's one of the real pleasures and the real rewards that we get, is that the idea that we could take an early esophageal cancer and deal with it in 15 or 20 minutes as an outpatient. 10 years ago, the discussion I would be having is, here's what it takes to have your esophagus removed. What a difference.
Oh, yeah, well, but that's why I really, first of all, I thank you for being here, but I feel happy when I'm able to give that kind of information back out to the people that watch these shows. It happens to me so often that people will stop and say, oh, if I didn't see that on the show, I never would have done it. And I'm not going to get into those stories, but talking about endoscopy, because it's so prevalent. I mean, believe it or not, my first profession, which I haven't been involved in since the early 80s, was pharmacy, all right? And I can tell you, I remember that I lived in the era of Maalox and J-Usul. I mean, we used to have it stacked up to the sky, cases of it, And I think in my mind that now, I say to myself, why was there no due diligence or vigilance? Maybe it was because of non-training, non-knowledge, whatever it was. But it would seem to me that in your field today, you could mitigate, if someone came to their family physician, their primary care physician, and they express some issues relative to indigestion, burning or whatever, it's so oversimplistic. I don't mean to state that, but it's so really oversimplistic to them to refer to someone like you. Correct?
Yes.
So take me from there.
So what you're referring to, first of all, I want to say that my father was a pharmacist, so I share an admiration for the whole field, and that's one of the reasons why I got into medicine in the first place, was just the understanding and the chemistry and the physiology of how drugs work in the body. But what you're referring to, reflux, is an extremely common condition. It's perhaps one of the most common conditions that affect patients, and we realize that it does affect quality of life significantly. Food choices, dietary, lifestyle choices are modified because of this symptom. We fortunately have a good array of medications that can affect the symptom complex, the natural history of the disease, and now we also have endoscopic options to not only monitor these patients, but to also potentially reverse the reflux cause and potentially allow them to come off medications. So this is certainly one of those areas where patients seek our advice. Unfortunately, there are now many options to consider on the table other than just medications that we can provide for our patients.
Dr. Steinberg, I mean, like I said, you've seen the changes over the years. So
I have, and I think your point's really important. People who are needing to self-medicate for a variety of reasons, particularly with respect to reflux disease, ought to see a physician, their primary care doc or their gastroenterologist, because it's manageable. We have really good ways to deal with those problems, and the vast majority of those patients can be restored to essentially 100% normal quality of life with usually some relatively modest interventions. So you hate to see people who have been suffering for a long time for something that we have easy solutions to.
And I'm going to get back, either one of you can jump onto this, but we hear a lot about hiatal hernias as well. You want to explain to the folks what a hiatal hernia is, either one of you?
Sure. So a hiatal hernia is a very common finding. It's basically an anatomic problem where part of the stomach, which normally resides in the abdominal cavity, is pulled up into the esophagus or into the chest area. The reason why it's important is that exposes or predisposes the patient to having more reflux type symptoms. The natural barrier that the diaphragm puts on the stomach to prevent acid from coming up is changed when you have a hiatal hernia. So it's a very common finding, and it's a common reason why people may have more reflux type symptoms. Fortunately, when it's small, it's something that can be fixed endoscopically. The longer patients wait to address it, it may need to be managed surgically, but it's a very common finding.
Is that also, may I ask, when you do a surgical intervention, is that done minimally invasively? I mean, is it done
Yes.
endoscopically? Or how? I mean,
So
just
it
explain.
depends a little bit on the size and the appearance of the hernia, but many times it can be managed endoscopically. If it cannot be managed endoscopically, it's typically done in a minimally invasive surgical approach, a laparoscopic repair, and really only rarely would it require a more invasive surgery.
Another question that comes often is that people, I don't know, I guess it must be psychological, they have fear of anesthesia. My view, and you can attest to this, but my view of a lot of your procedures are really, you have minimal involvement with anesthesia. Is that correct?
Well, so our procedures are done under propofol.
Right.
People refer to that as the Michael Jackson drug.
Yeah, well, whatever.
But the good news is that it's a drug that puts people to sleep quickly, allows them to wake up quickly without a hangover, without any after effects. And it's really made our procedures much more streamlined, much easier to do, much safer. And so, for example, we do all of our procedures with a board-certified anesthesiologist in attendance all the time. And so I think the concerns that people have are perhaps more than they should. It shouldn't keep them from undergoing something that's important to them. Obviously, nobody should have anything done to them that they don't need. And so I think that's the starting point. But I think once you're in a situation where something needs to be done, anesthesia and concerns about anesthesia certainly shouldn't keep you from, proceeding down that pathway. So
I'm not asking you to rank, but what is the most common problems that you deal with, Dr. Simmons?
Well, we deal with an assortment of problems in our own practice. Most of what we deal with is related to early cancers involving the GI tract, the esophagus, the stomach, the colon, and we also commonly manage conditions of the pancreas and bile duct. That's the vast majority of what our patients are coming to us with. Of course, we can manage any problems involving the GI tract, but as a specialty consultation practice, we work with gastroenterologists to help manage their patients.
Right. So among the procedures that we do is something called endoscopic ultrasound, which is relatively new. I say that, I think I did my first one in '93, but that's when things were getting started. And it's a procedure where we actually have an ultrasound probe on the end of an endoscope, a probe such as one might have during pregnancy, except it's fitted on the end of a scope. It's tiny, so that it allows us to pass that scope and the ultrasound probe down the esophagus, the stomach, and out into the small intestine. And we can then look through the wall of those structures at whatever might be next door. And so, for example, we might be asked to look at the lymph nodes in the chest in somebody who has lung cancer. We might be asked to look at a thyroid nodule that's not accessible from the front. We're frequently asked to stage esophageal cancers. Endoscopic ultrasound is the most important modality for staging esophageal cancers, gastric cancers, pancreatic cancers, rectal cancers. And so it's become an extraordinary tool for us because it allows us to get imaging to areas and to places where we couldn't previously visualize very well.
That's really very interesting.
Because we can see those areas, we can also now do therapy in those areas. If we can see it, we can do something. We can place a seed, as I mentioned before, a fiducial for radiation therapy. We can place a biological that might have, be incorporated into the tumor's DNA and have a salutary effect on the cancer. We can instill drugs. We can do radiofrequency ablation, heat therapy, cryotherapy, a variety of different modalities that suddenly become available because we can see something that otherwise wasn't able to be visualized.
That really is very interesting, and I think that's the effect of trying to bring people like yourselves to the show is to make these folks out here understand that, number one, there are ways in which they can live their lives through without the horrors of, I guess, the intrusive nature of cancer and other things that will kill them. But the treatment variances, which are somehow psychologically embedded in their minds that are not available, but that's why I ask people like yourselves to come here to let them know that not only is it available, but it's life-changing and it includes many years of more healthy opportunities to do what they want to do. It's oversimplistic, Dr. Forcione.
Yeah, and I wanted to bring back the issue that you mentioned earlier, which is patients have fear of procedures, have fear of anesthesia, and often will use the internet as a source of medical information, which has extreme danger to it. Of course, it can provide some information, but it's important that patients do not use that as direct medical advice and that they see their physicians to help guide them. There's a lot of misinformation on the internet, and technology moves extremely fast. So it's important for them, if they have symptoms, if they have uncertainties about their symptoms, their disease, their treatment options, that they see their physician. And now that we have our practice and our expertise available to them, we can be a resource for them because there are many options available.
Well, that's the reason why I asked to get you all here, because again, I'm trying to mitigate the fear and yet instill some confidence in the viewing public to know that there really shouldn't be any fear, and that the knowledge of the problem, the quicker they get to be able to know what the problem is, the quicker you can use your talents in the various subject areas that
I think it's really, really important. The number of times that we see people that have been distraught, spent weeks worrying about something that actually didn't and shouldn't have caused them concern is sometimes heartbreaking. You get people who come in and they've been putting their affairs in order and talking to children about this and that, and to find out that the thing that they were worried about and that they had researched on the internet or their brother's uncle's butcher or whomever, it turned out to be something that didn't need to be of great concern to them at all. And so, obviously they should find somebody that they trust, and they should utilize that person because training and experience matters, and people can help them in ways that, that if I were to go on and to research a pharmacy issue, I would understand the words, but I would have nothing near the insight that you do about the implications of what I'm reading.
Well,
and I think that's that's true of everybody who's an expert in whatever area.
A long-term removed from that, but I will tell you that I when I owned my pharmacies, all my pharmacies practiced clinical pharmacy. We had a lot of arguments with a lot of physicians at the times, but didn't make any difference. We were very successful. We're down to the last, believe it or not, down to the last 3 minutes of this show. I just want you to, in your closing, first I want to thank you both, but in your closing, just to assure the people that are watching that they, number one is that you've made it very clear that your minimally invasive interventional techniques they're not necessarily pleasant, but they're near pleasant, and they're easy for them. It's easy on them to allow them to use your knowledge. So it's all yours. Go ahead.
Thank you. So thank you for having us. So I think what's important to tell the viewing individuals is that there's not one treatment that will be for everybody. It's a very individualized approach, and that's where some of the confusion may come from patients reading on the internet about all the different options. And the reality is that there are many options for most diseases now, ranging from medications to minimally invasive endoscopic procedures, that seeing an expert in the field can help identify what is the best treatment for that particular individual.
Dr. Steinberg?
Yeah, I think that I second Dr. Forcione's comments, and I think experience brings a great deal to the patients. Between the two of us, Dr. Forcione and I do as many of these kinds of minimally invasive procedures as anybody in the country. It's important, I think, for the viewing audience to know that 95% of our procedures are outpatient procedures. So these are not, 3-day stay, 2-day, not even overnight stay procedures. They are, the procedure ends, they wake up, an hour after they wake up, they go home. The impact on their lives is generally rather small, and they shouldn't be avoiding things that might be of great use to them and great help to them by virtue of fears that may not be founded.
Well, I think we got that was a great last sentence, because that's exactly where I wanted to end up, and I really appreciate both of you for being here. Welcome to our lovely community of South Florida. Thank you for your long service.
Pleasure.
You both are with the Center for Advanced Therapeutic Endoscopy at the Boca Raton Regional Hospital. We thank you both for being here. And folks, if you have any questions, you have any comments, there's an email address right here and a telephone number. Just let us know what they are, and we'll pass it on to the doctors. They are collaborative. That's what I keep on telling you. Healthcare in the very near future is not going to be one doctor in one office and one doctor in another office. It's going to be a lot of collaboration, because knowledge is something which is very, very handy when you have to battle, shall we say, danger and ignorance. How about that? So again, this show is called Dateline Health. We come to you from Nova Southeastern University. My name is Fred Lippman. Until next time, take good care of yourself. See you.